Hello everyone, my name is Carla. I am here to present my practicum project on implementing family-centered care in the NICU. First, I want to introduce you to what is family-centered care, or FCC, in the NICU. FCC is an approach to medical care rooted in the belief that optimal health outcomes for neonates are achieved when their families play an active role in providing emotional, social, and developmental support throughout their baby's NICU stay. It is critical to the development of the child for parents to be active participants in their care throughout hospitalization. On top of bonding with the infant, parents learn crucial information and skills from NICU providers that prepares them to care for their baby after discharge. Healthcare providers who deliver family-centered care are respectful of and responsive to individual patient preferences, needs, and values, and ensures the patient's values guide all clinical decisions. In this presentation, I will review and reflect on family-centered care practicum project. I will discuss the following topics: site or organization, needs assessment results, project topic, goals, outcome, stakeholders response, handoff for FCC implementation, my professional goals and AONL competencies, and lessons learned from the practicum project. Let's start with site or organization. My practicum site was Oliver UCLA Medical Center, or OBMC UCLA for short, a Los Angeles County hospital located in Sylmar, California. OBMC UCLA has affiliation with David Geffen School of Medicine at UCLA and belongs to the Health Services Los Angeles County and serves the communities within the San Fernando Valley. I did clinicals here as a student nurse, and I have been working here since 2017. Although my preceptor is the supervisor in the operating room, my practicum project involves the neonatal intensive care unit. We are a level 3 NICU with a bed capacity of 16. We are a small unit of 4 neonatologists, 8 hospitalists, 35 registered nurses, 7 respiratory therapists, 2 occupational therapists, 1 social worker, and 2 clerks. I found my passion working in the NICU, and I love working with mothers and their strong and mighty babies, which is the reason for my drive to develop family-centered care at OBMC UCLA NICU. With that said, let's discuss the needs assessment. I knew about the need for family-centered care because our NICU participates in the California Perinatal Quality Care Collaborative, also known as CPQCC, a statewide network of California's neonatal intensive care units. CPQCC's mission is to improve the quality and equity of healthcare delivery for California's most vulnerable infants and their families, from birth and NICU stay to early childhood. With that said, CPQCC found that one way to address the disparities in the NICU is by providing family-centered care. So, participating NICUs are asked to submit data on the following measures: days from NICU admission to first skin-to-skin care, days from NICU admission to first social worker contact, and hours from birth to priming with colostrum. These measures are known to increase family-centered care in the NICU. I highlighted skin-to-skin care because this is the goal for my project, which I will discuss later in the presentation. Let's dive deeper into the project topic, family-centered care in the NICU. We can deliver family-centered care in the NICU by adopting the philosophies of the paired care model. The paired care model is from the Quality Improvement Toolkit created by Florida Perinatal Quality Collaborative. This is the CPQCC equivalent in the state of Florida. The development of this project is inspired by this toolkit. Paired represents the core domains of family-centered care, which are 1. Participation in care and decision-making, 2. Dignity and respect in identifying every infant and family as individuals, 3. Respectful collaboration with families, and 4. Information sharing regarding education for families on medical care. The staff received education on each of these domains on how they can apply it in their clinical practice. The paired care model will lead us to successfully achieving our project goal. As I mentioned earlier, skin-to-skin care, or SSC, is one of the measures of CPQCC for family-centered care. That's because skin-to-skin care has a variety of benefits for both neonates and mothers. SSC improves oxygen saturation, reduces cortisol levels, assists with growth and thermoregulation, and helps stabilize hypoglycemia for neonates. And it promotes bonding, improves milk volume, and stimulates the release of hormones that decrease stress levels in mothers. The positive outcome related to SSC is the reason why I chose the following as the goal for this practicum project: to achieve a 20% increase from baseline in the percentage of infants who receive skin-to-skin care from at least one family or caregiver within 3 days of clinical eligibility, as defined by the readiness assessment for skin-to-skin care with infants 30 or more weeks post-menstrual age by December 2023. As a side note, the Readiness Assessment for Skin-to-Skin Care provides the NICU team with SSC guidelines to determine whether an infant's condition allows for or does not allow for skin-to-skin care. Unfortunately, I was not able to implement the project because our unit was relocated into the old nursery from March to June 2023 due to a construction project in our NICU. The old nursery is perhaps only a quarter in size to our actual NICU and resulted in the barriers I encountered for this project. Therefore, I will instead be discussing the anticipated outcome in this part of the presentation. Here are the anticipated outcomes for FCC implementation. 1. The paired care model is adopted, which changed the culture within the unit to deliver care that is individualized to each neonates and their family's preferences, needs, and values. 2. There is an increase in SSC because of the NICU team's collaboration, which allowed us to achieve the goal of increasing the percentage of infants who received skin-to-skin care within 3 days of eligibility. 3. Training for staff and education for parents on FCC is incorporated in the unit's structure. And 4. A revision is done on existing policies or procedures to include domains of family-centered care, skin-to-skin guideline, and training or education for stakeholders. Now I will talk about stakeholders' response to the project. I was able to complete training and education on all staff members, and they were all excited to implement family-centered care. But when we're back home in our actual NICU, the relocation of the NICU led to the barriers on implementing this project, barriers that were too big to overcome. The limited space led to unsafe work condition, which led to burnt out nurses and doctors, and this led to high turnover rate in bedside nurses and even led to a nurse practitioner's decision to resign. This is the reason why I postponed this project to a future date, which will be July 2023 to December 2023. There is no handoff for the next steps performed since I am simply postponing the implementation of my project to a later date. I will still be the project leader at that time. Although I couldn't implement my project, I have everything we need to implement the project in July. I was able to get approval to utilize the following resources in our NICU. The new resources are the Welcome to the NICU Guide, which is a pamphlet that introduces families to our NICU, provides teachings on FCC and SSC as well. Second is the Readiness Assessment for Skin-to-Skin Care, which I mentioned earlier, and this provides guidelines for SSC based on neonate's condition or circumstances. Third is the patient survey, which is a new discharge survey will be given to families that now incorporates FCC and SSC. And fourth, the FCC training and development that will be used to train and educate all current and future NICU staff on FCC and will be incorporated in the orientation packet for new hires or new staff. The plan is for staff to complete annual competencies on FCC starting next year. Now that we're at the end of the program, I can honestly say that I have learned so much about myself and how to become a great leader. I have been asking myself, what's next for me in my nursing career? Here are the professional goals I have set for myself and the AONL competencies I hope to achieve. One of the professional goals that I have set for myself is to become a servant leader. I hope to become a servant leader as a manager or supervisor, preferably within the maternal child department. For now, I will lead the maternal child unit practice council to help develop an EBP culture within labor and delivery, postpartum, NICU, and pediatric inpatient unit. The AONL competencies I hope to achieve is related to communication and relationship management. I want to improve on these competencies because leaders must be able to communicate effectively with stakeholders, to influence behaviors, to gain cooperation from others, and to manage relationships to keep them engaged and interested in achieving common goals. This goes hand in hand with servant leadership because servant leaders fosters employee engagement, enhances teamwork, improves communication, develops a higher level of trust, and in the long run improves organizational performance. The ultimate goal is to see employees, colleagues, the organization, and our community succeed because their success is my success. Although servant leadership is the biggest lesson I learned in this course, the most important lesson I learned from the project is the importance of performing a readiness assessment for project implementation. Performing a readiness assessment for project implementation 4 to 8 weeks before any change initiative is a great way to identify any needs to assure readiness to carry out the implementation plan. This step allows us to evaluate the organization in terms of structure and culture to perform at current and future state, people based on their skill, experience, and motivation, technology, how new and existing technology can impact the project, process where we put together the guiding team who will provide support for process changes, and reality by assessing current conditions, support, and execution of the project. Leaders must be able to recognize gaps and find solutions to issues to ensure that the organization is ready to execute the project. I am thankful I did a readiness assessment for my project because that's when I recognized that our team was not ready for this quality improvement project at this time. I just want to say thank you, Professor, and to all my classmates in this course. Congratulations to us, and I want to wish everyone good luck in your future endeavors as a leader in healthcare.